Okay, so good evening, everyone. I want to welcome you all to today's presentation. Special greetings to our consultants and fellows on the call. So today we're going to have an overview, a discussion of stress ECG, stress echocardiograms. By 45 minutes max, we should be done. So this is going to be the outline of the presentation. We're going to look at some case scenarios. We look at the modalities of stress echocardiography. We look at the principles behind it, especially in evaluating coronary artery disease. We look at the summary of the test modalities when it comes to stress. We look at how stress echocardiogram is used to assess the regional wall motion abnormalities, the indications for stress, the echo, the common protocols, how to interpret it, and pros and cons of the various modalities of stress echocardiography and the limitations. So the first case scenario reads as follows. We have an 82-year-old female patient with a history of calcific aortic stenosis, hypertension treated with ACE inhibitors, and renal failure with creatinine of 2 milligrams per deciliter, has New York Heart Association class 3 dyspnea, and was recently hospitalized for heart failure. She has been treated successfully with diuretics. Her blood pressure is 135/65. Body surface area is 1.8. Her heart rate is 90 beats per minute. The EKG showed sinus rhythm with no evidence of acute ischemic changes. He did an echocardiogram. Transthoracic EF is 75. The end diastolic diameter is 4.1. LVOT is 2.1. The left atrial volume index is 35 ml per meter squared. And he has grade 2 diastolic dysfunction. So these are the dimensions for the resting echo. As you could see, the LVOT is 2.1. The stroke volume is 59. It's already been calculated to make it easy. The stroke volume index is 32 ml per meter squared. And your maximum aortic gradient, as you can see, is there. The mean is 30 with Vmax of 3.6. And your aortic valve area is 0.84. Okay, what will be your best next step in evaluation and management of these patients? So we have to make it interactive. So in summary, you have an 82-year-old known to have calcific aortic stenosis, history of heart failure, comes in with dyspnea. BP is 135/65. Aortic valve area, EF is 75, preserved. LVOT 2.1, left atrial volume index 35, grade 2 diastolic dysfunction. You do a T transthoracic echo. The stroke volume index is 32 ml per meter squared. Your aortic valve area is 0.84, and your mean gradient is 30. What will be your next step in evaluating these patients? So let's make it interactive so that we don't spend much time, so that you can have the remaining time for the day. Dr. Chineme, do you want to take a shot at it, or Dr. Corey?
Sorry, Eugene, I'm a little distracted. I'm actually driving.
Oh,
So
okay.
I'll prefer if someone else takes it.
Oh, okay.
Okay, Dr. Eugene, let me try. But from the parameters you've shown, I think this is like what is it called? This thing, a low gradient AS. Is there another word for it? But I think for this patient, it's like an intermediate this thing. I think the next step for her would be to do a stress echo. I think I've seen this somewhere in one of the past one of those books, and at the end It was a stress echo. I can't really remember, but I think it's because of the low gradient AS, they call it, like so that you can differentiate if she really has an AS or not.
Oh, okay.
That's what I can say
Yeah, your, your,
about it.
your your answer is correct. And to differentiate whether it has AS, but I'll take another option again, contribution. Thank you very much, Dr. Chinemi. I think Dr. Adebayo Mojid, you can unmute and go ahead. You raised your hands.
Yes, looking at the scenario, is looking like a patient that have a severe symptomatic low gradient AF with a normal ejection fraction.
Okay.
Now, if you look at the 2020 R guideline, because he has a normal ejection fraction and he's still having a low gradient, the next line is to do a computer tomography angiography to actually confirm the severity of the AS. However, if the patient now has severe, assuming he has a severe low flow, low gradient with a depressed ejection fraction, we now talk of the use of the low dose dobutamine stress test because this patient is symptomatic. In a patient that is symptomatic, usually you don't want to take them through the rigor of the dobutamine stress test. But in those ones that are asymptomatic, you can actually go ahead to do a stress test. But in this scenario, the next line for this patient, because it's symptomatic, it will be more of computer CT angiography for this patient.
Okay. Did you mean CT scan or CT angiography?
Cardiac.
So a CT scan looking at the aortic valve, that's what you are suggesting?
Yes.
Or you are talking about angiography, CT coronary angiography?
It's CT coronary angiography, rather.
Oh, okay. All right. Thank you very much. So, like you both rightly said, your patient has evidence of severe aortic stenosis based on the aortic valve area, 0.84 cm squared per meter squared. However, there's a discordance. When you have severe aortic stenosis, you're expecting your mean gradient to be 40 and above. Now, if you look at it, your mean gradient is 30. So now the question is, you have someone with aortic stenosis, but the mean gradient does severe aortic stenosis, but your mean gradient does not meet the diagnostic criteria for severe aortic stenosis. So the question is it because of something? That's why the gradient is not much. So if the EF is low, like you said, it means that the patient may not be generating adequate gradient across the valve. So it could be low flow, low gradient, AS. So this is severe aortic stenosis, low flow, low gradient. But in this case, the EF is preserved, like you rightly mentioned, Mojid. And that inform your decision not to push for your dobutamine because your EF is preserved. However, if you notice, the stroke volume index for this patient, though EF is preserved, was 32 ml per meter squared. So that is the catch. The EF is preserved, however, your stroke volume is still reduced. So this is a patient with a paradoxical low flow, low gradient, not a typical low flow, low gradient where EF is reduced. This EF is preserved, however, your stroke volume is still reduced. So in this patient, you want to be evaluating this patient. Yes, he's symptomatic, but is the symptoms as a result of the severe aortic stenosis? Or is it because of a pseudo-severe aortic stenosis? Because that will inform your decision to go for surgery. Yes, like you rightly mentioned, you can do the CT scan, but you can use that to evaluate the severity. But you still want to know, is this gradient significantly above the criteria? So this patient can still have a stress test, but like you rightly say, it's 80 something, so you can do a treadmill stress test, all right? But you can still do a dobutamine stress test, and you can do the low dose dobutamine stress test to evaluate the gradient across the aortic valve to ascertain whether indeed you are dealing with a severe aortic stenosis or you are dealing with a severe aortic stenosis. Remember that this scenario demonstrates the use of the continuity equation in deriving the aortic valve area. And we all know the limitations of the continuity equation. All right, so we'll go to the next one. So this is the next scenario. A 50-year-old hypertensive, diabetic, and dyslipidemic reports with a 2-week history of exertional chest pain relieved by rest. Chest pain occurs when climbing a hill or stairs or walking about 200 meters. It is not progressive and does not limit functional capacity. However, he is concerned about the cause of the chest pain. He reported to a hospital and the attending doctor requested a 12-lead ECG. So this is the 12-lead ECG. Okay, so 50-year-old hypertensive diabetic dyslipidemic, chest pain when climbing hill or stairs or walking 200 meters. He's fine in terms of function. He's just concerned. Reports ECG shows this. What will be your next step in evaluating this patient?
Dr. Eugene, please, can we see the ECG?
Can you go back to the ECG?
Any take, please. Dr. Kenneth Enyedi, Dr. Chimezi Udeneka, Felix Awindago, Dr. Wusu.
Can you move the screen to the question again?
To the question. Yeah, Charles, kindly go ahead.
Yeah.
Just make sure you are safe. I don't want you to be arrested for talking on your phone.
No. I've reached my house.
Okay.
It's okay. All right. So okay. Just if you can go back to the question, I'll be glad. All right. So we have a 50-year-old hypertensive with a 2-week history of chest pain, and the chest pain looks angina because it's what when he's climbing a hill or walking some distance. So in the ECG, what I could pick out was a left bundle branch block pattern. Although you didn't tell us whether this ECG is, but I believe it's a rest.
Oh, it's a resting ECG.
I believe it's a resting ECG. Yes. So what we could pick out is a left bundle branch block. So the question is, well, there are many. The question is the best next step in the evaluation and management of this patient. Well, what he has looks like an anginal pain. It looks like stable angina with chest pain on exertion and relieved at rest. Okay, so what this patient, the options will include, he will need a CT angiography, CT coronary angiography, yes, CT coronary angiography. I think that would be a good option for him. Okay. Then we also need to find out if he has regional wall motion abnormalities on echo, on stress. Okay, of course, he would have done an echo, so he may also need a stress echo. Okay. That's my take on it.
Okay, thank you very much. So with respect to the stress echo, which modality of stress echo are you recommending?
I don't know the modalities of stress echo.
So treadmill, dobutamine.
Okay, you mean treadmill or dobutamine?
Or dipyridamole, adenosine, which option will you prefer? Or let me say treadmill stress echo and pharmacological stress echo, specifically the dobutamine. Between these two, which option will you go for?
Treadmill stress echo, so that we can elicit what happens while because if he has the symptoms, so you can elicit the symptoms and actually see the diagnosis.
Okay, thank you very much. Thank you very much. Thank you. So, like Dr. Okori rightly mentioned, you remember in evaluating a patient with chest pain, what informs your decision is the pretest probability of coronary artery disease. So ideally, this patient's pretest probability of coronary artery disease has to be calculated or estimated based on the recommendations as we know them. So there are several tools. There's the CAD Consortium pretest probability tool. There's several of the tools. Now, if you do your pretest probability, you know that you may have intermediate less than 15%. If it's less than 15%, then it's unlikely coronary artery disease, so no further evaluation. Between 15 to 85%, it means that your patient is intermediate. So your options are stress echo, stress ECG, CT coronary angiogram. 85% and above, of course, invasive coronary angiography. So if you estimated this patient's pretest probability of any of the two, it will be at least moderate. Yes, so CT coronary angiogram is a good option to go. In terms of stress echocardiogram, it's also a good option to go to evaluate your patient. However, the caveat is that you should know that for treadmill stress test, your patient has a baseline left bundle branch block. And so interpreting your treadmill stress echocardiography has a limitation. If you look at specifically this patient because of the baseline left bundle branch block. So this scenario draws our attention into some of the benefits between the various modalities of stress echo. Whereas LBB is a contraindication for treadmill stress test, you can still be able to do a dobutamine stress test in the presence of what LBB. So just this scenario was to draw that distinction of in terms of benefit in the different modalities. So this takes us into our modalities of stress echo. You have exercise stress echo. It could be treadmill. It could be bicycle stress echo. It can be pharmacological stress echocardiogram, which you can have the most commonly used one, dobutamine stress echo, adenosine stress echo, dipyridamole. Now, Dr. Okori made mention of an important point, which is the fact that the treadmill stress test is always the one preferred as a means of stress for stress echocardiogram because it's more physiological and is able to elicit the ideal state. And you can have stress echocardiogram patient with pacemaker by inducing the stress by pacing, increasing the atrial pace to cause that. Now, what is the principle behind the assessment of coronary artery disease by stress echocardiogram? Essentially, the main reason for stress over the years, stress echo has been coronary angiography, coronary artery disease, even though there are other benefits, but mainly core is what? Coronary artery disease. Now, when you stress an individual, when there's increased workload on the heart, which is determined by your rate pressure product, which is the heart rate times your BP, which you see on the horizontal axis. Now, as you stress every individual, the workload on the heart increases, there's increased oxygen demand. Now, while the increased oxygen demand goes up, then the point is, at what point will you have the relative ischemia, where there will be evidence of decreased perfusion? Because if there's increased demand and there's evidence of if there's obstructive coronary artery disease, then they will get to a point where you will be unable to get adequate blood supply. So if you look at it, if you have a 90% stenosis, you understand the evidence of reduced perfusion, diastolic dysfunction, will occur way earlier on minimal stress compared to if it was 50%. Now, most of the times we tend to intervene with obstructive coronary disease when it comes to PCI or revascularization, usually 70% or more. So if you look at the 70% curve, you notice that the first thing that begins to become a problem under stress is what? Reduced perfusion. And that is why the stress PECT and SPECT are able to pick these changes earlier than expected. Before you have diastolic dysfunction, then regional wall motion abnormality, which is what is capitalized by the stress echo. All right. Before you even have the ECG changes, before the patient will have chest pain. And when the patient goes into the rest stage, this process reverses itself. So that is the principle behind it. So the perfusion scans pick this early. Things that, because the main thing is, first of all, is a relative redistribution of flow with the relative ischemia before this diastolic dysfunction, regional wall motion abnormality, and others also occur. Now, when you are resting and you are contracting in systole, you notice that the endocardial border moves inwards and the walls thickened, as is beautifully illustrated on the left side of the screen, where you see thickening with endocardium moving inwards towards the cavity in end systole. Whereas under stress, if you look at the stress curve and you start developing the regional wall motion, which in this case is affecting this territory, notice that the thickening here is reduced compared to the thickening on that side and endocardial movement. And that is what you are capitalizing on when it comes to stress echocardiography. And so when you notice this regional wall motion abnormalities under stress, then they suggest evidence of obstructive coronary artery disease. Now, all the modalities that I use have their benefits and disadvantages, or what describes them. Now, dipyridamole adenosine is mainly for coronary blood flow and not necessarily to assess flow reserve, not necessarily regional wall motion and ischemia. So when it comes to stress test for coronary artery disease, it's mostly dobutamine in terms of the pharmacological agents. Now, you look at the physiology for the exercise stress and you compare the different parameters, it tells you which area of the physiology that the emphasis is on. So for example, if you look at heart rate, you notice that both dobutamine and the bicycle treadmill test increase heart rate significantly compared to the dipyridamole adenosine, which are mainly as more perfusion. And if you look at stroke volume too, you notice that the exercise stress test is more physiological and increases your stroke volume significantly compared to the dobutamine, which may be no change in your stroke volume or may even reduce your stroke volume. And in terms of blood pressure, there's significant increase in your blood pressure by treadmill or exercise stress compared to dobutamine. So we should understand some of the differences in terms of the physiological response with these modalities with exercise. Now, in assessing regional wall motion abnormalities, we need to recall I think most of us will have seen this before, have this in our echo labs, various guiding us on which territory is affected in the presence of regional wall motion abnormality. Now, we all know regional wall motion abnormality, as you could see below, is defined as either normal, hypokinesis, akinesia, dyskinesia, or aneurysmatic. Now, you notice that each is assigned a score of 1. So normal is 1, hypokinesia is 2, akinesia is 3, dyskinesia is 4, and the dyskinesia is in systole. Whereas aneurysmatic is dilatation or bulging out of a part of the wall, even in diastole, that's 5. And we'll use it to do the wall motion score index, which essentially grades all the 17 segments if you are using the segment 17 model as a denominator. And if you score each of the segments 1 and it's normal throughout, that's 17 over 17. So it will give you a score of 1. So a wall motion score index of 1 is what is expected in a normal person. This goes further to characterize the parts just for revision. Now, I've already spoken about this in terms of the grading of wall motion abnormality. Now, this also talks more about the response in the various modalities when it comes to the stress. We can later look at this. Now, what are the indications for stress echocardiogram? Evaluation and prognostication of coronary artery disease. That was the main reason for stress echo. It has a sensitivity of 88% and a specificity of 83% for obstructive coronary artery disease. Now, if you have a low pretest probability, it is going to increase your false positive rate. So we need to make sure the indication is right. At least patients will have an intermediate or moderate pretest probability of coronary artery disease. Now, it relies a lot on good image quality. You need to see your endocardial border clearly. You need to be able to appreciate the thickening and the inward movement on the cardio. And also requires that the person should be able to elicit or adequate heart rate for it to induce that enough workload on the heart to elicit a positive test. If you're a suboptimal stress, then you are likely going to increase your risk of a false negative report. Now, also, if you have a small area of ischemia, you may miss it, especially if there's a hyperdynamic state and you're evaluating warm motion abnormalities. For example, dobutamine can induce a lot of hypercontractility, and the basal segments may be difficult to appreciate in a regional warm motion. So those are some of the things we need to know. For myocardial viability, so for hibernating segments where you are assessing viability, the low dose dobutamine stress test is helpful in assessing viability in an area that has ischemia. And the sensitivity is 75 to 80%, and specificity is 80 to 85% in identifying viable segments with functional recovery after revascularization. Now, if you're able to demonstrate viability by the dobutamine stress echo, it has a sensitivity of 86 to 90% and specificity of 71 to 90% for predicting improvements of the patient's global heart function and outcome. So it's a very good tool to use. Now, more so now, valvular heart disease, like we first learned from our scenario. So aortic valve area is less than 1 centimeters, your mean gradient is less than 40, and your EF is low. The typical low gradient, low flow, but your aortic valve area clearly shows that it's severe aortic stenosis. You want to find out whether it's a true aortic stenosis or not. Dobutamine stress echocardiogram has that benefit. So if you're able to demonstrate a good increase, 20% increase in your stroke volume compared to baseline, it suggests that your patient has a good contractile reserve and surgical outcome is good compared to someone who does not elicit that adequate increase in stroke volume and has severe AS. Now, for pseudo severe or functional AS, your left ventricular outflow tract VTI will increase and the aortic valve gradients will marginally increase or remain the same despite doing the stress test. Now, for mitral valve, if you have an increase of greater than 15 millimeters of mercury in your transmitral gradients, or an increase in your pulmonary artery systolic pressure to above 60 millimeters of mercury, is consistent with a significant mitral valve stenosis requiring surgery. Now, if your pulmonary pressures increase, but there's no change in your transmitral gradients, then look for another cause other than your mitral valve stenosis. Now, if a patient has ischemic MR and you do stress, then the inferior wall will develop what's worsening regional wall motion abnormality and your MR will worsen. And that lays credence that you are likely dealing with an ischemic mitral regurgitation. Now, diastolic function, we all know when it comes to the diagnosis of HFpEF at rest, it may be very challenging because in HFpEF, there are other confounders that may give you the symptoms. So in diagnosing HFpEF at rest, you may have your left atrial pressure being normal based on echo, E over E prime, maybe less than 14 at rest, even though the criteria for HFpEF says if you look at E over E prime greater than 9 as part of the inclusion criteria, but most of them may not demonstrate evidence of increased left atrial pressure as assessed by tissue Doppler at rest. So you may want to stress, and during the stress, evaluate the diastolic function to see whether it increases with stress. Now, for risk stratification, like I said, if you look at the warm motion severity index, someone with a score of 1 is what? Low risk, 1.1 to 1.7, intermediate, greater than 1.7 is high risk. And each of them is associated with a 0.9% rate, 3.1%, and 5.2% adverse cardiac events, respectively. So the higher your warm motion severity index, the higher the risk of adverse cardiovascular events. Now, if a patient exhibits what we describe as transient ischemic dilatation, where under stress, the entire LV dilates in systole instead of reducing in size, then you have about 19.7% adverse event rate per year. So it's a very good tool for risk stratification. And now, for example, for patients who are going for surgery, peripheral vascular disease, he has a positive predictive value for adverse event and outcome of 13% and a negative predictive value of 99% for postoperative outcome. So it's a very good tool for risk stratification. Now, what are the common protocols that are used? The common protocols, our colleague will be presenting on stress ECG. Will go into details. Most of the times, this presentation is good to come after a stress or a treadmill ECG presentation. So the commonest protocol is the Bruce protocol for the treadmill, and there's also the bicycle protocol. But we all know the Bruce protocol. We'll be going into detail into that later, so I won't go much into that. But let's know that Bruce protocol, and also there's the supine bicycle protocol of the bicycle stress test, where if you know the bicycle stress test is also in terms of the energy demand, start from 25 watts all the way up. The advantage of the bicycle stress echocardiography over the treadmill stress echocardiography, you see, with a bicycle, you can do the echo as the person cycles through the event. So you can tell where regional wall motion abnormality develops at what stress load, at what rate pressure product. You understand? You can determine it because the patient is in a position where you can do the echo whilst going along. Whereas for the treadmill stress test, apart from you do your baseline echo, the person goes onto the treadmill and your repeat echo to assess regional wall motion or pressure gradients across the valves, etc., diastolic function and everything is done within 60 to 90 seconds when the person comes off the treadmill. You understand? So you have a very limited opportunity to evaluate your patients. So you have the rest, then during the recovery, immediately after the peak stress for treadmill. Whereas for the bicycle stress, you have the opportunity to evaluate the patient throughout all the stages. Same as the glutamine stress test, you have the opportunity to evaluate the patient throughout the stages. The benefit of treadmill over the others is that for treadmill, you are able to give the adequate workload, optimal workload is physiological. There are some references which say that even for the bicycle protocol stress test, you might not be able to achieve even 85% of the maximum predicted heart rates. So they may define what a positive test result is at a particular rate pressure product. If you're able to achieve that rate pressure product, it's enough. Some protocols, for example, from some hospitals in the US, may say even if you achieve 70% on a bicycle protocol, it's enough to give a report. So, but for workload, treadmill stress test is the best to give it adequate workload. Now, if you look at this, so essentially a patient has come for a stress test, you've checked your indications, the name of the person, there's contraindications, you've checked it. You make sure the indication is right, your patient is on the treadmill. If you are going to use a treadmill test, before they go, you've done your baseline ECG, 12-lead ECG, you've done your BP. Like I said, this presentation will be easier after the presentation of stress test. But essentially, before you do a stress test, checking the indications, the contraindications, your patient lies down, you do a 12-lead ECG, you check your BP, you have your baseline parameters before they go on to the treadmill test with all the electrodes connected and they start the stress test. Now, whilst they are going through the stress test, you are monitoring the patient's clinical condition. Is he having symptoms? Is the patient complaining of chest pain, dizziness, etc.? Are there ST changes on the ECG, etc.? Blood pressure response. You're looking at all that. But for stress echo, what you are looking at is to stress the person to the peak, and then immediately come off the stress test and recovery quickly. You capture your images. So you have your images at rest, the echo images at rest before they go onto the treadmill, and you compare it with the images, the videos, whilst in the early part of the recovery phase. If it's a treadmill test, if it's a bicycle test, you have your rest echo with all the parameters, like you can see, you know your LV function, your original warm motion, you've assessed all at rest. And whilst you are going through the bicycle stress at 25 watts, you evaluate. At 50 watts, you evaluate. So that one you can evaluate till they get to the peak and then to recovery. So that's the benefit of the bicycle over the treadmill stress test. So, like I said, baseline echo, you look at the LV function, structure, original warm motion, etc. Then they do the exercise. Then you look at immediate post-exercise. So if you look at this image here, you have the so usually you put it's a quad image reporting. For all images, you compare the rest to the stress. So on the left of the screen, this is a 4-chamber, this one. Yeah, the apical 4-chamber was at rest. Then you have the apical 4-chamber doing stress. That is after peak stress. So because you're doing a treadmill, you can only evaluate the stress component after they've gotten off within that early recovery period. And you notice that from this representation, there was original warm motion. This is not a video. There was original warm motion abnormality in that territory. Same was also noticed in the 2-chamber. So essentially, you are comparing your rest to your peak stress. Just that for the treadmill test, you can't compare it with the peak stress whilst they're on the treadmill. They have to come off the treadmill. Then quickly you capture your image, your videos in cine loop images. So you should understand the challenges. It means that the patient's heart rate can drop significantly from the peak after recovery, and you may not be able to appreciate any original warm motion because the workload has reduced. That's one of the limitations of the treadmill that we should appreciate. Okay, now for the dobutamine, do the same thing. You do your baseline echo, you give your dobutamine infusion. Okay, every 3 minutes you will see the protocol. Then while you are moving from stage to stage, you can do your echo. Unlike the treadmill, like I said, you can only do it after the peak. So you could see we start at 5 mic per kilo. So you can evaluate the heart function, what's the stress with 5 mic per kilo, which is typically like the low dose of vitamin that can be used to evaluate myocardial viability up to 10 mics. Okay, you get to 10 mic, you are evaluating. So what's your EF at 10 mic? What's your original warm motion abnormality? What is your diastolic function? You get 20 till you hit to the peak, which is 40. Now at 40 mic per kilo, if you're unable to achieve the heart rate that is necessary, most literatures will say 85% of the target heart rate, as we know, but the American Society of Echocardiography on stress echo said a minimum of 80%. So if you're unable to achieve that, then you will use atropine to augment to achieve that target heart rate. So this was also elicit demonstrating similar findings. So you have at rest and also on stress. So the top images are rest images, apical 4-chamber, compared to the one below it, which is at peak stress with the dobutamine. And the arrow demonstrates that under peak stress, that area exhibited original warm motion abnormality. And also the same was also mentioned for shown for the 2-chamber. Now this is to let you know the low dose. You know the normal dobutamine goes all the way to 40 mic per kilo, but the low dose goes to 10 ideally, and this is mainly to elicit viability, myocardial viability, because if you have hibernating myocardium, the low dose dobutamine, they demonstrate thickening of the myocardium, and under high dose, they develop original warm motion abnormality, which is the biphasic nature of hibernating tissues. So that is how you can use it to assess viability. Now, this is from the American Society of Echocardiography 2020. their key points on. They said for treadmill exercise protocols, images obtained at rest and immediately after exercise should be compared side by side using the quad screen format, which we show. So you see the images in four view. So whichever view you are using, if it's parasternal short axis, that rest, you should compare to the same parasternal short axis under stress. If it's apical, four chamber, you compare. Apical, two chamber, you compare. So you can acquire a lot of videos in cine loops, but the comparison should be the same. You don't compare apical four chamber rest to apical two chamber stress. For pharmacological stress echocardiography, images from peak stress stages should be compared to rest, low dose, and pre-peak or early recovery. So like we said, you have the opportunity to go through 5 microgram all the way to 40 micrograms. So you can compare in between stages. Unlike treadmill, you can only compare the rest to the recovery, the early recovery phase after the peak exercise. Now, obtaining data from multiple cardiac cycles at peak stress enhances the accuracy of the test. So you want to acquire as many images as possible. Now, exercise stress test is more physiological, like we mentioned, than pharmacological stress tests, and include a prognostically important finding of patient's exercise capacity. So you can predict functional capacity of the patient with treadmill stress test. You can do that with the dobutamine stress test or the pharmacological stress test. The bicycle stress echocardiography is technically more feasible for assessment of both coronary blood flow reserve and diastology because you can grade the workload and still be able to evaluate your function. The dobutamine stress echo is a preferred alternative test for evaluation of myocardial ischemia when patients cannot exercise. So it's very important to note that. Then diagnostic endpoints include achievement of at least 80% of the age and sex predicted workload for exercise testing and target heart rate for dobutamine stress echo. So 80% minimum. For treadmill, 85%. Now, how do you interpret it? A normal ventricle has a normal vent size and wall thickness and EF 50% and above with no focal wall motion abnormality. So your wall motion score index is 1 because the 17 segments are all normal. So they all score 1, 1, 1. That will be 17 divided by 17. Now with stress, your LV becomes hypercontractile. There's increased oxygen demand, increased workload on the heart. So your LV cavity will shrink. Now, the presence of a baseline wall motion abnormality that remains fixed with stress is indicative of a previous infarct. Now, if you develop a new or worsening wall motion abnormality, then it's suggestive of a flow-limiting stenosis in the coronary artery supply to that segment. Now, if you have a large ischemic territory like left main or multivessel disease, then it will manifest as a diminished global LV ejection fraction and chamber dilatation with stress, which is called the transient ischemic dilation. Now, with respect to the severe AS, the low flow, low gradient aortic stenosis. Now, if you're able to elicit stroke volume increase of greater than or equal to 20%, then you know that, like we said, your outcome post-op is better. You have good reserve. So your stroke volume has increased to more than 20%. Your mean gradient has increased to greater than or equal to 40, okay? And the aortic valve area is less than 1. It's a true aortic stenosis. But your mean gradient is still less than 40 despite increase in stroke volume across the LVOT and the aorta. And your aortic valve area improves under the dobutamine stress. And then also pseudo aortic stenosis. Now, you can also look at if your stroke volume is less than 20%, it means the heart itself is already struggling. The flow reserve is not good. So you can't rely on the dobutamine stress test to conclude much. Why? Because the idea is to generate adequate stroke volume, but you're unable to increase the stroke volume to achieve a good interpretation. Then that's why you can do the multi-slice CT scan and the calcium score, which was mentioned earlier by our colleague there as a good option. I think one of our colleagues mentioned that when we started the scenario. Now, if you do that and the CT comes and says it's high, then you're dealing with a true aortic AS. But if it is low, then it means that you're dealing with a pseudo severe aortic stenosis. Now, these are the advantages of the various modalities and disadvantages. So treadmill, high workload, there's a lot of data on it. The disadvantage is that it's only post-exercise that you can do the imaging. For bicycle, you can do the imaging during the exercise. The disadvantage is that they mostly will not achieve the workload that you want compared to treadmill stress tests. The Dobutamine too, you can do continuous imaging, and the other benefit is that it doesn't require physically active patients. So for patients who cannot do stress tests because of physical limitation being their contraindication, then you can do dobutamine. Okay, the level of stress achieved may not be adequate compared to that of treadmill. That's the disadvantage. And dobutamine too can give you side effects. Okay, now for the vasodilator agents, they are mainly to assess more of flow inequality and not necessarily ischemia per se. And for those with pacemakers you can pace to stimulate the increased demand. What are the limitations of stress echo? It requires a good endocardial definition because you want to see the endocardium move inwards during systole. You should be able to appreciate the thickening, but it may be challenging if you have very poor windows. And so you can improve that by using ultrasound enhancing agents together with your stress echo to improve delineation of the boundaries. Now, a lot of cardiac and respiratory motion. Imagine someone walking up, running on a treadmill, and afterwards you have to evaluate the heart, the respiratory parts, and the breathing, the deep breathing in and out can make imaging quite challenging. And you may have inadequate stress or workload, which will influence your interpretation of the results. And if the patient already has an abnormal resting LV function, it makes the interpretation of regional motion a bit challenging than usual. Now, how do you report it? These are the components of reports that is needed when you do a stress test. The baseline regional wall motion has to be commented on. Your stress regional wall motion that you elicited, the protocol you used, the dose, was the test adequate or not? What was the workload? Was target heart rate achieved? You understand? If ischemia was not detected, but stress was inadequate, you have to make a statement on that. Okay, so essentially at the end of this, you conclude, is it normal? There was evidence of ischemia, there was fixed wall motion abnormality or combination. Thank you. So I'll pause here for contributions, corrections, questions, then we can call it a day. Hello?
Eugene, we can hear you.
Any questions, contributions? It's either I've confused you or I said nothing. Okay, Charles, go ahead.
Yeah, thank you, Dr. Eugene, for an excellent presentation. Also, thank you for always stepping in and leading by example. I have some confusions actually that I want to ask you. Number one, when we're talking about aortic stenosis, especially in the first case scenario, there are some things I didn't get. What's the difference between a low flow, low gradient AS and the paradoxical aortic stenosis? And also related to the pseudo AS, just help differentiate these three as regards to how you differentiate them on stress echo. That's the first thing. Then I also didn't get the role of stress echo in mitral stenosis. Why do you want to do a stress echo in a patient with mitral stenosis? Does it help identify a severe MS? I don't know.
Okay.
Then the last one, sorry, please, is well, this one is I'm just wondering. It's not. I think there should be a way. But I'm just wondering. You said for the bicycle one, you can actually do it while the patient is. You can do unlike treadmill that it's a post stress. for bicycle, you can actually do it. So I'm wondering, how will you do it? Just, do people actually do it? How will you do it as the person is cycling and you have a
Okay.
probe on the hand? I'm just wondering. It's not looking feasible to me. So just if you can explain.
Okay, so you look at this picture to start with that last one. You see how the bicycle is. So if you look at the picture on the first slide, so you have all your electrodes connected to the patient, your BP curve, someone is checking the BP, and there's the cardiologist or echocardiographer is doing the echo. Do you appreciate it? So
Yeah, it's possible. I can see it.
you see it now, yes.
But you likely will not have good images because of movement.
So that's the limitations, but this one is better even than the treadmill test in terms of image quality because you are acquiring your image not necessarily under pressure because you are evolving. Whereas the treadmill test, immediately they get off the treadmill as soon as possible, within 90 seconds, you have to acquire as many images as possible. So yeah, that's why you have to train. The person has to be trained and work together as a team. So you require that efficiency. Now, with respect to your so you see, so if you look at this, your patient's EF is 75%. So the EF is normal. You understand? But your aortic valve area is 0.84 cm squared per meter, which means that your aortic valve area is severe aortic stenosis, okay, in the presence of a normal EF. However, for severe aortic stenosis, you want to have a mean gradient of greater than or equal to 40. But your mean gradient is what? 30. You understand? So you don't, this your mean gradient here is 30. Your aortic valve area is 0.84. So there's a mismatch. Why do I have an area that qualifies for severe aortic stenosis, but a mean gradient that qualifies for moderate aortic stenosis in a patient who is symptomatic? You understand? So does my patient have severe aortic stenosis and symptoms due to this AS and therefore will require surgery? You want to be certain. Because severe AS symptoms, heart failure, previous is surgical intervention. But you don't want to choose a wrong patient for the correct procedure. So now you want to find out, is it severe? Now your EF for this patient is preserved. If your EF was reduced, then that one you can say that you are not generating adequate gradient across the aortic valve because the EF is low. So that will be your typical low flow, low gradient. You understand? Because the EF is low. That one is straight, it makes sense easily. But there's a patient whose EF is 75. It means the EF is preserved. So if the EF is preserved, ideally, the patient should be able to generate adequate flow across the valve to elicit the maximum mean gradient. But despite the EF being 30, this patient still is not generating adequate stroke volume across the LVOT. And your stroke volume is what? 32 mil per meter squared. So if your EF is normal, why are you still not being able to generate adequate stroke volume across the LVOT? And so that's what is making it paradoxical, that your EF is normal, but you are still unable to generate enough gradient across the LVOT, and your stroke volume index is low. The stroke volume index cutoff is 35. So if your EF is good, you should be able to generate a good. So if the EF was 75 and the stroke volume index was 40, this patient will not require, you won't go and do the dobutamine stress test. Why? Because the patient is already generating adequate stroke volume across the valve. But this patient, despite the EF being good, he was not generating adequate stroke volume across. The stroke volume index was less than 35. So the paradoxical nature here is because the EF is normal, but still not generating adequate stroke volume across compared to low flow gradient who already has a low EF. Please, do you understand that one?
So I understand. Excellent. I understand. Thank you. So the question is, why is this one not generating enough EF? That's
Yeah,
actually the
so I'll
question.
come there. So
As in, why is it not generating enough gradient? Sorry, not EF.
yeah, so the reason why you can have paradoxical low flow, low gradient is in patients who have severe hypertension or significant diastolic dysfunction. In this patient, the blood pressure was not markedly high, but he had grade 2 diastolic dysfunction. So in the presence of significant diastolic dysfunction, despite the not good EF, you will not be able to generate adequate stroke volume across. So this scenario is in fact this question is from AXAP, the American college, you know, they have questions where they evaluate your thoughts at different chapters. So that is a typical question from AXA.
Okay. So this patient, so likely when you have like high left atrial pressures.
Yes, when
That's
your pressures are high, or there's severe concentric LVH, that can also give you a paradoxical low flow, low gradients.
It's clear. Thank you so much.
You're welcome.
Then the question on mitral stenosis.
So, remember we mentioned that you may have a patient who has a mitral valve stenosis, and is probably, per your evaluation, your patient is having moderate MS. But he's having symptoms that you are not certain whether the symptoms is from the valvular stenosis or is from something else. So if you evaluate with a stress test and the patient fulfills that criteria of developing a gradient of greater than 15 with pulmonary pressures going above 60, then it means that the mitral valve stenosis is significant and requires surgical intervention. So in situations where is ambiguous, you are not certain whether this mitral valve stenosis is what is causing the patient's symptoms and so requires surgery or not, then you can use the dobutamine stress test, provided there's no contraindication. Yeah.
Okay, so come again, what are you supposed to see on the stress test that makes it positive?
That's also that the gradient will increase by more than 15 millimeters of mercury.
Okay.
And your pulmonary systolic pressure will go above 60.
Okay. It's clear. Thank you so much.
You're welcome.
Thank you.
Dr. Eugene, I just want to say you're a fantastic teacher. Thank you. And then Dr. Okore for asking the question, because I didn't even know the question I was going to ask, but I know I didn't understand some things. So thank you so much. At least it's clear now.
Thank you for your kind words. So on that note, we'll continue tomorrow. And please, let's try as much as possible. I'm encouraging, even if you are the one answering 330. So far as you are going to join the meeting, please prepare for your questions so that in case if a colleague genuinely could not make it, we still are able to solve questions to move along and carry everyone along. Okay, and the colleague also presenting tomorrow too. For now, I've not had any communication, so I know we are doing the presentation tomorrow. So God willing, I will all meet 8 p.m. Nigerian time. Have a wonderful evening.
Thank you, Dr. Eugene. Good night, everybody.